First of all, I would like to thank the invitation to about this particular point. I'm trying to share my screen with you, but for some I am not it. So I will try to solve this problem, sharing the screen with you. I am going to speak to you about the lessons that we have learned treating patients with multiple myeloma in constrained settings. Okay, I will try to address several points, starting with the name of multiple myeloma. Multiple means more than one. Myeloma is a tumor of bone marrow cells, and multiple myeloma is more than one tumor of bone marrow cells. So we must accept that there are several myelomas, myeloblast myelomas, neutrophil myelomas, eosinophil myelomas, megakaryocyte myelomas, and plasma cell myeloma. So the correct name of the disease that we are addressing should be plasma cell myeloma, not multiple myeloma, as most people say. I learned this semantic situation from Professor Robert Peter Gale, who is very careful about the way that we refer to some diseases. In 1982, I spent some time at the Mayo Clinic working with the Mayo brothers that founded this clinic several years ago. And I spent some time with Bob Kyle, which, as you know, is one of the big guys in the multiple myeloma treatment. In 1983, this picture was taken. Here is Bob Kyle, Maury Gertz, Phil Gripe, who already passed away, Tom Witzig, John Garton, John Lust, and myself. So I spent some time at the Mayo Clinic, involved mainly working with aplastic anemia, but I got involved in this research, and we ended up publishing this paper about how circulating lymphocytes in the peripheral blood express plasma cell antigens, a condition that is now being explored with more detail. So what about the treatment of this condition? Well, there are two situations: treatment of plasma cell myeloma in optical circumstances, or treatment of plasma cell myeloma in underprivileged circumstances. These are the countries, the low and middle income countries in the world. So what I'm going to address is the treatment of multiple myeloma in these conditions, which represent more than 82% of the inhabitants in the world. That indicates that only 18% of people living in the world can have access to the novel treatments of multiple myeloma. The other thing that I have to address also is that this phrase by Elizabeth Kubler-Ross, which refers to myeloma and some other conditions, we have to ask ourselves whether medicine needs to remain a humanitarian and respected profession or a new but depersonalized science in the service of prolonging life rather than diminishing human suffering. This refers to myeloma because I am not fully convinced by now that disease-free survival is better in myeloma than overall survival. So we have to take this into account with the considerations that we are going to address. Initially, I will speak very briefly about the treatment of plasma cell myeloma in optimal circumstances, and I will use some information provided by Shaji Kumar in the recent symposium in Los Angeles. Key is delivering best tolerated, most effective initial therapy to reach the maximum possible depth of response and maintain there. I'm not fully convinced about this. For transplant-eligible patients, PI plus IMID plus anti-CD38, autologous HSCT for consolidation, proteasome inhibitors, my IMIDs or anti-CD38 maintenance till progression. This is extremely expensive. And for transplant ineligible or deferred, proteasome inhibitors plus IMID plus anti-CD38 if tolerated. If not, data with Revlimid and dexamethasone and these other options. And treat the relapsed disease at the earliest evidence of progression. These are the suggestions to treat patients with multiple myeloma in optimal conditions, which I must admit are not applicable to people living in underprivileged circumstances. The studies that are required to make the molecular cytogenetic classification in plasma cell myeloma are also difficult and are not available in most developing countries. And as I said, these are the recommendations for transplant eligible and transplant ineligible patients. In our hands, I would say that 95% or more of patients with multiple myeloma are transplant eligible. So I will address now the treatment of plasma cell myeloma in underprivileged circumstances. And I will refer to some history between 1978 to 2022 in Clínica Ruiz. The first paper published in myeloma in our country was published by my father, Guillermo Ruiz-Arguelles, in 1978. He is a clinical pathologist and he deals mainly with the classification of multiple myeloma. Here's my father, which is currently 98. My brother was also heavily involved in myeloma. My son, who is a hematologist, and myself. We have all worked together working for persons with multiple myeloma. I will use some information stemming from our center, referring to the treatment of persons with multiple myeloma in underprivileged circumstances. And I have to say, what one major point in the development of the treatment has been the use of simplified methods for stem cell autografting in multiple myeloma. I will also use some data about this publication concerning long-term survival in multiple myeloma, which seems to be in our hands longer than that described in Caucasian populations. And also I will address this review that I made with Professor Gomez Almaguer about lessons learned treating patients with multiple myeloma in research-constrained settings. So I start with thalidomide 100 milligrams a day, aspirin 100 milligrams a day, dexamethasone 4 milligrams per week by mouth, and bortezomib, if possible, 1.75 milligrams per week, irrespective of the body surface area of the patient, and by the subcutaneous route. Bortezomib is very important in the initial treatment of patients with multiple myeloma, but it is not strictly necessary. We have found that 1 week is same as one bortezomib per week is same as 2 per week, and we use half a vial. Vial is 3.5 milligrams. We use half a vial, and we store the leftovers up to 6 weeks, and we deliver it by the subcutaneous route. You are well aware of this paper about the stability of ionized bortezomib in the original manufacturer vial. So there's no need to discard the leftovers of bortezomib. So this indicates that 1 vial is good for 2 weeks of treatment in patients with plasma cell myeloma. So start with Velcade, thalidomide, and dexamethasone if necessary. Do the autograft when the monoclonal spike goes down. Maintain the patient with thalidomide and switch to lenalidomide only if toxicity ensues. This is substantially cheaper, as I will show. And employ novel drugs only in relapse. The method that we use for grafting patients for multiple myeloma is conducted on an outpatient basis. And we have learned several lessons also concerning bone marrow transplantation after 30 years of doing this in our experience. We started to graft patients in 1993. We have done by now 1,696 transplants. And the main indication for autologous transplant is multiple sclerosis, followed by multiple myeloma. We have also shown that you can transplant patients either with oral melphalan or IV melphalan, and despite the fact that the results are better using IV melphalan, the results are okay using oral melphalan. So you can use the tablets instead of intravenous presentation, which in some parts of the world is substantially more expensive. What about the IMiDs? We use regularly thalidomide. Lenalidomide is only used in patients which are intolerant to thalidomide, and in very few cases we employ pomalidomide. So we use thalidomide until the patient develops peripheral neuropathy. And the data that we have found is that there is no major difference in the overall survival of persons with plasma cell myeloma given thalidomide or lenalidomide. So in this period, we studied 227 patients with plasma cell myeloma. The median age was 57 years, and some of them had HSCT, and some others did not. These are the salient features of 108 patients that were eligible for analysis treated at Clinica Ruiz. And initially, they were treated with thalidomide and dexamethasone, or Velcade, thalidomide, and dexamethasone. Some of them were given and others not autologous stem cell transplantation. The main reason of not grafting them being socioeconomic conditions. And all of them were maintained with thalidomide, and they were switched to lenalidomide only if they developed peripheral neuropathy. This is the overall survival of the patients treated with this approach. It's above 157 months. And as you can see, there is no major difference between those treated initially with VTD as compared to those treated initially with thalidomide and dexamethasone. There is also some difference, which is not statistically significant, between those given hematopoietic stem cell transplantation and those not given hematopoietic stem cell transplantation. And there is also some difference between patients that were grafted after either thalidomide dexamethasone or Velcade thalidomide dexamethasone. Now, what is interesting is that after the transplant, patients were maintained with thalidomide, and this could be done in 70% of patients. This indicates that most patients, specifically 70%, do not develop peripheral neuropathy and can be kept on thalidomide, whereas 30% are given lenalidomide. The difference is not really significant, and this indicates that you can maintain the patient either with thalidomide or with lenalidomide. The years of treatment also are important. We have learned to give more supportive measures to patients with plasma cell myeloma. And now we have also found that the proportion of patients treated this way, which are long-term survivors, is substantially larger. In our hands, using the method that I just presented to you, the 5-year overall survival is 75%, and the 10-year overall survival is 55%. The main variables being associated with the long-term survival are HSCT age and ISS stage. This is the overall survival of the patients in this paper. And see, those that are given HSCT do better than those that are not given HSCT. Allogeneic HSCT is very infrequently conducted in our experience, as happens in most places around the world. And there is another, this is also interesting, younger patients with multiple myeloma do better than older patients with multiple myeloma using the treatment that I depicted to you previously. These data are consonant with what has been published about this multiple myeloma in Latin America, in which for some reason patients with multiple myeloma in Latin America seem to do better than patients with multiple myeloma from Japan and China. So there may be some genetic susceptibility to have good results in the treatment of patients with multiple myeloma. This is the data that we have obtained in our experience, up to 150, which are similar to this one in other places in Latin America. These are data from Mexico. Now, this is a picture of the world in the night. The places in which there is much light are the places in which there is money. And we, unfortunately, cannot look over this condition. And money is the main reason why we have to choose one image above the other, and this being the reason why we employ always thalidomide. Thalidomide in our hands costs 100 milligram a day, $81 during 1 month, whereas lenalidomide is $5,715 in our experience. So this indicates that lenalidomide is 70 times more expensive than thalidomide. And since we have shown that patients do the same after the transplant if they are given thalidomide or lenalidomide, we employ thalidomide every time that it is possible and switch to lenalidomide only if toxicity ensues during the treatment. These are costs to some other drugs. Pomalidomide is even more expensive than lenalidomide, bortezomib. Generic bortezomib about 25% of the cost, and carfilzomib also very expensive. This paper deals with the prognosis of patients in Latin America treated either in the public versus the private practice management. And the difference are clearly in favor of the private practice patients. And the main reason to this is that they can afford some more expensive and novel drugs. So, wrapping up the lessons that we have learned at treating patients with multiple myeloma in resource-constrained settings, these are our salient recommendations made by Professor Gomez Almaguer and myself. Keep the patient the longest time in the best possible conditions and avoid financial toxicity by employing novel drugs. Start treatment with thalidomide and dexamethasone, including possible bortezomib. There is no major difference in including or not bortezomib. Conduct an outpatient autologous transplantation in all patients, only those that have a formal contraindication. Employ thalidomide as post-HCT maintenance, probably not in high-risk cases in which lenalidomide may be useful. You can keep the patient on thalidomide in 70% of cases and only switch to lenalidomide in 1/3. Follow the patient with serum protein electrophoresis and free light chain measures. Employ the novel drugs only in case of relapse or refractory disease. And do not forget supportive therapy. These combinations of daratumumab plus lenalidomide and dexamethasone, daratumumab plus pomalidomide plus ixazomib plus dexamethasone, and pembrolizumab plus pomalidomide, which are very useful in the setting of well-developed countries, are almost unavailable in low and middle-income countries. Probably the most game-changing drug in the treatment of relapsed persons is daratumumab, and Vincent Reshkumar once told me that the only real game changer in myeloma is daratumumab. Again, we have to very carefully analyze if disease-free survival is significantly better than overall survival, asking ourselves whether medicine is to remain a humanitarian and respected profession or a new but the personalized science in the service of prolonging life and sometimes prolonging agony rather than diminishing human suffering. Our final recommendation is this one in the treatment of persons with plasma cell myeloma. KISS. Keep it simple, stupid. And this is a very famous KISS in San Diego, California, that once belonged to Mexico and that now is part of the United States of America. I use this final picture of my family to thank again Arthur for his kind invitation to share with you these ideas about treating patients with multiple myeloma in underprivileged circumstances. And I dedicate this lecture also to my family, my wife, my son, who is also a hematologist, my other two sons who helped me in running the clinic, and my grandchildren, which are by now 7. I also use this opportunity to thank all the persons that have spent some part of their time to listen to these considerations. Thank you very much.
Thank you, Professor, for this very interesting speech and this regarding the situation of the patients with multiple myeloma in Mexico. It's very interesting. My question is regarding the access to the autologous transplantation. What percentage of your patients in your institute can have autologous transplantation as a first-line therapy?
Well, in our experience, around 50% of patients can have autologous transplantation having multiple myeloma. This stems mainly from the fact of the cost of the procedure, despite the fact that we have made several changes to make it affordable as conducting them on an outpatient basis and so on. It's still an expensive procedure. This ending up of the condition of being able to graft about 1 out of 2 persons with plasma cell myeloma in our condition.
Thank you. And Professor Ruiz-Arguelles?
Great talk. Congratulations to your lecture. And my question is regarding costs. You mentioned that Revlimid is so expensive. We know this, but I remember that we took lenalidomide from Mexico. It's like $50. You have not, it's a factory in Mexico. You have not this generic?
What is very affordable is thalidomide in Mexico. And the reason to this is that leprosy was never cleared from our country. So thalidomide was always there to treat patients with leprosy. So thalidomide is still a very affordable drug. Lenalidomide is, as I said, substantially more expensive than thalidomide. There is generic lenalidomide in Mexico, and we get the generic lenalidomide in Mexico from India. We do not have generic lenalidomide made in Mexico. We get it from India, and it works about the same.
Okay, thank you.
I actually have a question regarding something else, because I have noticed on your chart showing a number of transplantations that you have performed 1,300 transplantations for multiple sclerosis. It's probably more than worldwide. Is it true?
Yes, by now we have done 1,400 transplants in persons with multiple sclerosis. We transplant persons from all over the world, and by now we are the largest center in the world as far as number of patients with multiple sclerosis being given an autologous transplant.
Thank you very much.